Our next speaker is Joel Voss. He's from Northwestern University, and he's going to talk about evidence needed to validate non-invasive brain stimulation for neurocognitive modulation.
Thank you. I'm actually 85 years old. I've been receiving transfusions for my children for the last 63 years, so you're on to something. Okay, so, sorry. Everybody wants to change the brain in a useful way, and if anybody could, they would probably rule the world. So there has been an explosion, especially in recent years, at attempts to modulate the brain using non-invasive stimulation methods and other approaches like cognitive training. In recent years, these have part of the explosion in use of these methods has been due to the ease of application of some of them. So, for instance, some methods like trans-cranial electrical stimulation, you can go to the hardware store and for about $100, you can get some sponges and some batteries, and you can shoot some electricity into your skull somewhere. There's a big debate in the field whether or not these kinds of methods are useful. There have been some great success stories. There have also some evidence that these methods might not be as effective as we might think. And so what I'd like to do is highlight a little bit of the work that we've been doing trying to modulate the human hippocampal memory network, and to use some of our data points as sort of a blueprint for what I think needs to be done in these studies in order to better validate their ability to provide useful modulation of the adult brain. So I think that part of the story here is that the reason why there are some sort of false positive results that are getting a lot of attention is that the normal methods that we have to evaluate the effectiveness of interventions often don't cut it for things like brain stimulation. If you take the double-blind placebo-controlled trial as sort of the model of an interventional study, the kinds of methods that we're using are very complex. The opportunity for placebo and for non-specific effects are huge, and they're very hard to control. And so we have to do a little bit more, I think at least, in order to validate the utility of these methods. And so the specific points I'd like to go over that I think should be included in future studies using these sorts of techniques are the need to show within individual studies target engagement. That is, we know that the cognitive performance types that we care about are supported by large-scale neurocognitive networks, and we need to be able to show in our study using various metrics of specificity how well can the interventions that we apply have a specific effects on the neurocognitive networks that we care about. We need to show that the cognitive metrics that we use as outcome measures have specificity to these neurocognitive networks that we're attempting to target. We need to include within experiment control and comparison conditions in order to guard against non-specific and placebo effects. And we need to implement a variety of very rigorous experimental design and analysis methods that guard against all of these non-specific effects. So to give an example, my lab is studying non-invasive stimulation to target the memory network. And so the memory network of the hippocampus can be defined by methods such as resting state fMRI and others. So if you plant a fMRI connectivity seed in the hippocampus, what you'll get is these areas around the brain, often described as the default mode network. I'll be calling it the hippocampal cortical network, that show connectivity or correlated activity over time with the hippocampus. And so this network is involved in aging, so over the lifespan, the connectivity between the hippocampus and these cortical regions goes down, associated with memory impairment, and there's some evidence of dysregulation. As this connectivity goes down, interhippocampal activity kind of goes up, so it becomes cut off from the rest of the brain. So the question in my lab is, if we stimulate or try to stimulate this network, do we affect it? Can we have a measurable impact on the operation of this network? This is a strongly interconnected structurally network, so it's not as though it can only be defined using methods such as fMRI. Direct track tracing studies show that there's strong structural connectivity between these cortical areas and the hippocampus as well. So what we do in one example study that we published a couple years back, we would go into each individual subject and try to identify a spot within their individual hippocampus that we care about, and we're calling that the hippocampal target. That's the area we want to have an influence on. We use resting state fMRI in each subject to identify the network of that hippocampal target. This provides an area of the brain that we can stimulate, and the question really is, how does this stimulation affect this network? The kinds of methods that we're applying, we get baseline assessments on all people. People undergo 5 days of non-invasive brain stimulation using TMS. We know that TMS is getting into and affecting the brain because we calibrate it based off of our ability to move people's effectors around with pulses. So we can aim it at the motor cortex, make sure their fingers twitch around in a predictable way, and then apply that intensity to the other area of the brain that we care about, the parietal cortex. So they get 5 days of high-frequency TMS. They also go through a sham control condition, which they're not receiving stimulation, but go through all the same procedures in a counterbalanced order. And we measure the effect of stimulation a full 24 hours after the last time they received any stimulation whatsoever. And so what do I mean by target engagement? So this is our analysis of target engagement. What you're seeing color-coded up here is the magnitude of increase in correlation with the hippocampus of these regions of the hippocampal cortical network. So all these regions at baseline before anyone got any stimulation showed strong connectivity, correlated activity over time with the hippocampus. The effect of stimulation was to increase the magnitude of that correlation. So they became better correlated over time, showing that the stimulation protocol has a specific effect on the network that we care about. You see these are all regions of the baseline network of the hippocampus, and you don't see any other areas of the brain changing in connectivity that are not part of that hippocampal network. So we have high ability to modulate our targeted network. Another way of assessing that in the study that we do is, if you remember, we went in and we picked a hippocampal target in each individual subject based off of their anatomy. And so what we can do is we can say, well, in the hippocampus, that spot varied a little bit from one subject to the next. It was generally in the body of the hippocampus. But we can normalize everyone's data so that that's the same spot in space. And we can say, well, how much of this connectivity effect was really specific to the spot that we picked in each individual subject. And that's what this analysis is showing. Color coding at this hippocampal hotspot indicates that the largest change in connectivity is where we targeted, and the effect falls off with distance away from our target. So again, including a very specific measure of how effectively can we get at the network that we care about, target engagement. Okay. That stimulation protocol was associated with some improvements in memory ability, so people got better at memorizing a set of arbitrary paired associates due to receiving stimulation. But we've subsequently used more specific cognitive tests that we have tried to make sure are actually good metrics of this network of interest. So what we've done is we've used individuals that have unilateral hippocampal lesions, and so they have a lesion to the network that we specifically care about. We bring them in and we administer the following kind of test. It's a spatial memory test, so they're memorizing that this cherry happens to go in this particular spot of this background scene, and so they're just trying to memorize about 100 or so of these arbitrarily assigned spatial locations. It's a good episodic memory proxy. They're doing this kind of test, and we scored their memory in the following way. So you could count a general success of memory as being, okay, did you get the cherry in approximately the same location as what you studied it? This is sort of a global memory process that could be solved by familiarity, i.e. having a memory for the cherry went on the upper left. That's one type of memory. We also care about the precision of their memory. So given success, you get it approximately right. How precise are you of getting the cherry exactly back onto the specific spot that you studied it at? Our data in these hippocampal lesion patients, as well as other evidence from people with bilateral hippocampal lesions, show that this success metric is not really related to hippocampal lesion, but the precision metric is related to hippocampal lesions. And so this allows us to have a very specific hypothesis in our outcome measure. I'll show those data quickly. So in young subjects, compared to the temporal lobe resection subjects, there's no significant impairment in success. Higher values indicate more success. Here, lower values indicate more precision. The lesion subjects are less precise than young subjects, and elderly subjects are somewhere in the middle. At any rate, this allows us to have some idea that the outcome metric that we're using is specific to the process and the network that we care about. The other advantage of using this flavor of neurocognitive task is that it allows us to have a with an experiment control or comparison condition. That is, to the extent that our stimulation affects the hippocampal network and the precision but not the success component of the memory task is related to that network, then we expect that stimulation should affect precision and not success of memory retrieval. It's one nice feature of this is that we can pull out that dissociation within performance of the same task. So that is, the subject is trying to do exactly the same thing on every trial. They're trying to take the object and put it back to where they studied it originally. And so this allows us, for instance, if we were to study memory in a different way, say give someone a memory test and say, did we have a selective effect on memory as opposed to, say, performance in some other task like attention, then if the subject knows that they should be getting better at memory, they might try harder on the memory task than the attention task. And there can be other non-specific generic difficulty differences between tasks. Here, we can pull apart two factors differentially related to our network of interest within performance of exactly the same task, which is advantageous in dealing with all of those non-specific possible issues. And so what we found with this particular task, using the exact same stimulation protocol that I described previously and showed effects on hippocampal connectivity, was no significant effect on the success component whatsoever, but a significant improvement in the precision of memory. So relative to how people were at baseline, they improved by about 6% in the precision component of their memory after receiving a week of stimulation. And every single subject in our sample showed this effect. In the sham condition, people were at 50-50 in terms of showing the effect. And so we can find this, it's nice evidence that the effect of stimulation on this network is to improve the specific component of task performance that we think is related to the operation of that network. We've done a similar follow-up study in collaboration with Marcel Mejelam and Sandy Weintraub at the Northwestern Cognitive Alzheimer's Cognitorology and Alzheimer's Disease Center. In this study, we use a similar kind of within-task setup where it's not a spatial memory precision study, but we're doing item associative memory. So on each study trial, subjects are studying arbitrary pairings of objects to scenes. This allows us later on, we can test their memory for the objects themselves. So did you see an apple earlier on? Versus the ability to say, given this apple, which of a variety of different scenes did you study it with? The item component is not particularly specific to the hippocampal network. You can memorize apples and other kinds of objects without really having much of a hippocampus. But that associative component, being able to know that given this apple, I studied it with this scene, that is heavily hippocampal dependent. And so we expected a specific effect on that associative memory component within this task. That's what we found. I'm not plotting. There was no effect of, again, we administered the exact same stimulation protocol in a group of cognitively normative adults aged 60 to 85 years. There was no effect on the item recognition component, remembering which apples you saw earlier on. In the sham condition, you can see measured 24 hours after receiving any stimulation at all. Relative to baseline, subjects are getting about 5% better at the memory task, even in the sham condition. So there's a practice effect. They're getting a little bit better at doing the task. They stay a little bit better 1 week later on. After receiving 20 hertz stimulation for the week, though, you can see that there's quite a marked improvement at the 24-hour mark that lasts for a week later on. And these are using corrected p-values for all the multiple comparisons that we're making in this study. Okay, so those points highlight, those are actually data points that I'm going to show you that highlight these recommendations in terms of target engagement, specificity of our cognitive outcome measures, and within experiment control conditions. I'm going to offer a few more kind of recommendations that don't directly follow from the data that I'm presenting today, but are related to it. And so these kind of revolve around the idea of the need to implement rigorous experiment design and statistical analysis methods in this field in general. Of course, there's a current emphasis on making sure that all research being done that's supported by the NIH is rigorous and reproducible by including adequate sample sizes, making appropriate statistical corrections for multiple comparisons and such. Of course, we need to do that. In addition, I believe that this field in particular is sensitive to the file drawer problem. So that is, we run a study of brain stimulation. If we find something, we publish it. If we don't find something, it goes in the file drawer. And that leads to a difficulty in assessing whether there are true effects across a variety of studies. Pre-registration of study designs is an excellent way to address the file drawer problem, and it's only beginning to be implemented in our field. Another issue has to do with analysis methods. It's a very common practice in the non-invasive brain stimulation field to try to break treatment responders from non-responders. That's usually done off of behavioral criteria and then used to assess neural criteria. So for instance, half the people, you run a study that shows no effect whatsoever of brain stimulation, and then you take that half that happens to have shown an effect and the other half that happened to not, which will happen by chance. You break them up into two groups and you say, are there any neural differences between these groups? There almost certainly will always be a neural difference between groups defined in that way by chance. And so that's a good exploratory study, but it's not the end of, or should not be the end of any research study. Finally, or not quite finally, a lot of the methods that we use involve pain, discomfort, and other subjective states that could amplify or interact with placebo effects. Brain stimulation doesn't always feel very good, and it's very difficult to account for that. In order to account for it in our studies, we include a variety of control conditions, including both negative control stimulation conditions, that is, someone goes through the same procedures, we put the paddle on their head, and we just turn the amplitude down so that the current isn't actually getting into their brain whatsoever. So that's nice, but it doesn't involve the same subjective experiences. We also do positive controls. So for instance, in the experiments I described above, we stimulated a out-of-network location in the motor cortex to show that stimulating at full intensity in this other area doesn't cause any of the same specific effects on the hippocampal network and memory that we showed in our normal studies. So with that, I'd like to thank my laboratory and our funding agencies. Thank you.
Questions? Yes.
It's really interesting stuff. I wonder if you could comment on the distinction between using non-invasive brain stimulation as a tool to probe the function of a neural system versus trying to affect some function. It seems to me many of your comments, and they're very salient, are more directly relevant to the former. One could imagine that you're using non-invasive brain stimulation to try and improve memory, for example, that may not engage may not be mediated by the target system that you thought a priori.
I think that given the current state of knowledge in the field in general, it's a little bit premature to try to go out and use these methods as interventional tools without fully understanding their mechanisms. I think that could be very misleading in some ways because you can have effects due to a variety of factors that you can only later sort out, and yeah, so that could lead to a lot of research going down kind of blind roads, given the current state of knowledge of the effects of things like stimulation.
I had a question.
Yes.
Great talk. So in thinking
Talking
about
to them.
hippocampal engagement in your task, have you done the experiment where you stimulate the PFC and get similar effects on precision?
We are doing that experiment, but it's not done yet. So actually, we expect something different. So we actually expect the opposite, that success will be affected by the prefrontal stimulation and not precision. We're almost there, but we don't have the data yet. Yeah.
I also had a question. So many of the recommendations that you have for standards are similar to standards that we would have in other fields. So why do you think it's particularly a problem in non-invasive brain stimulation? Is it to do with marketing of this product? Or I mean, why in particular do you think it's a concern?
Well, I mean, I don't know. It could just be the kind of nascency of the field. There's been a kind of an explosion of research in this area in recent years, and so I think that with enough time, maybe the field will develop in a useful direction and implement some of these rigorous methods, but it's just not really there yet, and so I think there needs to be a push to implement some standards when it comes to these methods.
And is it particularly a problem with respect to application in older populations?
No, I don't think it is. Although the challenges become even more with older populations, especially the need for including evidence of target engagement. There's a big problem that we run into with our studies is that cortical atrophy is common among people with and without cognitive impairment. And what that means is that the distance between the skull and the brain is greater, and so you need more amplitude to get current down into the brain. There's a debate going on right now in terms of the trans-cranial electrical stimulation methods in healthy young individuals, whether or not that stimulation is getting to the cortex at an intensity sufficient to affect neural activity. With older adults, I think the problem is confounded. With our studies, for instance, the intensity that we're stimulating in terms of output of the stimulator system is almost twice as high in elderly individuals in order to create the same modeled effect on the cortical surface. And so it's kind of creepy. You walk in and someone's sitting in a chair and it sounds like a jackhammer is going off next to their head, but it feels about the same to them as it does in a young subject, and it's putting in the same amount of energy to their brain, just more intense at the outside.
Lee.
Yes, thank you. Did you have any problems with the Institutional Review Board, and how did you get that evaluated in terms of patient safety and the things that go with that?
No, we've not had any problems with our IRB. The methods that we're using have relatively small and relatively short-term effects on the kinds of tasks that we're using. Everyone in our studies also gets a neurological evaluation to make sure that they're not a seizure risk. We also assess neuropsychologically, and they get clinical imaging before, during, and after all of our stimulation protocols, and so we monitor for any signs of decline. We've noted these memory enhancements, but we haven't seen any evidence for any declines in anything we've measured, which includes a full neuropsych battery and a few other specialized tests of attention and other functions.
Thanks very much.
Thank you.